prematurity, more later bronchopulmonary dysplasia. Patient on chemotherapy, particularly bleomycin, if they get excessive oxygen therapy, they can also develop pulmonary fibrosis. As the absorption atelectasis, this also has been documented. Fire hazards, actually oxygen is a the inflammable agent, so fire hazards has to be kept in mind. And depression of ventilation, because hypercarbic drive is blunted, high PCO2, we all know this in the COPD patients particularly. Suppression of the hypoxic drive also, and this can depress ventilation. Absorption atelectasis, a few points about it. Nitrogen is usually relatively insoluble and exists 80% by volume of the alveolar gas. In the alveoli, most of the gas is nitrogen. Now it assists in maintaining alveolar stability. Oxygen therapy replaces nitrogen. Once oxygen gets absorbed into the blood, the alveolar will collapse, especially in the alveolar distal to the obstruction. So because the nitrogen is getting replaced from there, so nitrogen which were previously distending the alveoli to maintain it, preventing it from atelectasis, that is being replaced by too much of oxygen. And retrolental fibroplasia for the premature infants, below 1 month, excessive oxygen to the premature infants may result in constriction of premature retinal vessels, endothelial damage, retinal detachment, and possible blindness. Recommended PO2 between 60 to 90 millimeter mercury in the neonate. As I had said, 90 is the ceiling after which you never should try to achieve. So to conclude, oxygen is the most used and perhaps most abused drug in clinical medicine. Although it has never been considered as a drug, but of course with newer techniques and newer technologies and the newer understanding of oxygen, the importance of oxygen at the tissue level has given it a little bit of lift. Accurate knowledge and control over FiO2 is the fundamental prerequisite of oxygen therapy. As I had said, venti masks provide constant controlled FiO2 at 0.24 to 0.4, 0.5 without imposing functional apparatus gate space. Performance profile of no other device is uniformly available. That's why venti mask has been recommended as the first line of empirical therapy of oxygen, empirical oxygen therapy. Hyperbaric oxygen therapy neither widely applied nor firmly established in clinical practice. Although it is being used in various centers, but hyperbaric oxygen, role of hyperbaric oxygen is still debatable. There are many pitfalls of hyperbaric oxygen actually. So the take-home message is oxygen is a drug. First thing, we must understand that. Use it judiciously. Don't keep your all the outlets open, or whenever there is none, even the patient is not there, keep the outlets open or the devices open so that most of the oxygen is wasted. And prescribe it as other drugs. Amount, device and time should be specified. Whenever you write oxygen, just don't write oxygen. Oxygen through what? What is the FiO2 you want to achieve, and for how much time? 2 hours, 3 hours, 4 hours, 6 hours, 24 hours, whatever. If the patient's SpO2 is not good with nasal cannula, consider changing the device instead of increasing the flow rate. I have shown you that more than 6 liter flow through a nasal prong or cannula is not going to help anything. In fact, going to cause much more discomfort to the patient. Overzealous use of oxygen is often without justification and consideration of toxic effects of oxygen therapy. So think before such unaccounted for use of oxygen. So just there is something, some patient, something is happening, you cannot give anything, or you are not sure of giving anything, just give oxygen. It should not be used in that way. But last but not the least, that never withhold oxygen therapy from a hypoxic patient. Keeping that in mind also, you should never withhold oxygen therapy from a patient who actually requires oxygen for the hypoxic status. Thank you.